Okay, so we're going to take about 20 minutes right now. We're going to review a brief presentation on the evidence, very briefly, of accelerated resolution therapy and how it fits into the world of psychotherapy. And the purpose of this is so in future trainings, if it's Lainey or her disciples, that this can always be a part of it, and it helps frame where ART, we think, fits into the psychotherapy world now and potentially in the future. So it'll be about 20 minutes. Some of the slides I'm going to go through fairly quickly, and they will always be made available to you electronically. So even if you don't, capture everything right away, not to worry. We'll make these available. So we're using the classic definition of post-traumatic stress disorder, updated by the DSM-5. And as you know, these are the symptom clusters about re-experiencing memories, avoiding situations that would trigger memories. We will talk a little bit about negative cognitions and mood, and Dr. Hernandez will have a follow-on presentation that will touch on some of the way we view PTSD more as a memory disorder. So that's where the negative cognitions and mood comes in, and then the classic symptom of hyperarousal. So we're working within the traditional definition, and we realize that these trainings can be done in the commercial world or in the military world. It so happens right now a lot of our focus is in the military setting, although historically Lainey has done more commercial. So it's kind of toggling back and forth, but this is just some background that there's been about 2.6 million troops deployed to Iraq, Afghanistan, or both. And what we're seeing in our clinic now, and we're running multiple studies, is a lot of these individuals have multiple deployments, sometimes very lengthy deployments, so lots of trauma. And when you look at, well, what's the prevalence of PTSD and how does it compare to previous conflicts, the estimates are all over the map, and that's not really a good thing. You'd think that we could count better. They go from 2 to 31%, but it's because of different sampling strategies and different methodologies, but the best estimates are somewhere between 10 and 15%, with combat exposure being associated with a higher risk of PTSD. Here's a report from the Institute of Medicine saying 20%. I think that might be a little high, but nonetheless, it's in that 10 to 20% range. And an important feature, or important point, is that less than half of veterans seek treatment, whether it be in the VA and otherwise, and there's a whole host of explanations for that. But one of the things you'll learn in your training with the ART is there are some features that may predispose to people more likely to enroll in treatment, such as its brevity and that you don't have to share the details of your experiences. So some of the historical, I guess you'd say, roadblocks to seeking treatment may be minimized. Okay, one thing to keep in mind, and there's not a lot of literature on this, but this frames the background for this, is that when we talk about civilian versus military trauma, they're not necessarily the same. And in fact, a lot of the types of trauma are different. And so combat operational trauma, as I mentioned, a lot of times it's very extensive. We have people that have been in 8-hour firefights that we've treated, so those types of things. Long periods of stress, anxiety, and hardship. And then you have a whole host of other kind of factors, such as moral injury, and Dr. Hernandez will probably talk a little bit about that, prolonged grief. And I'm bringing this up not so much to do a comparison, but when we quickly and very quickly review the evidence, virtually all of it is based on PTSD treatment within the civilian world. So the evidence for the therapies to date are almost exclusively based on civilian populations, so there's no guarantee necessarily that those treatments would work equally as well in a military setting with differential type of trauma. That's the point of this. So no matter which therapy you look at, and again, we're going to frame this in the broadest sense, that the Institute of Medicine, completely unequivocally recommends that cognitive behavioral therapy is the only first-level treatment for PTSD, with sort of a mixed bag recommendation for pharmacotherapy. And by the way, these guidelines that you're going to review, it's not just within the U.S. This is within the UK. It's the Australian guidelines across the board. Okay? And what they say is, no matter how you package the therapy of all the approaches, that the core components of trauma-focused therapy, There needs to be a narrative element, okay? Cognitive restructuring, thinking about it differently or doing something cognitively, some type of in vivo exposure, reliving it in some fashion, okay? Some sort of relaxation called stress inoculation, and some sort of educational piece. So those are the components. And the therapies that are out there now and being investigated today have these elements in varying proportions, and you're going to get a good sense for which ones the ART uses a lot of. Okay? The relaxation in particular is a big piece of it, but you'll learn that throughout your training here. So when we look at what's currently endorsed, and again, this is by not just within the US, but internationally, these are the 4 evidence-based treatments. And we're not going to go into detail on them, but cognitive processing therapy, prolonged exposure, eye movement desensitization reprocessing, and stress inoculation training. So those are the 4, and this is based on decades of research. So it's not just overnight. There's lots of literature, lots of studies. Okay? What's sort of the take-home? Again, we are way oversimplifying this, but part of the take-home is when you look at these, they're usually 10 to 12 sessions or so. Sometimes they have practice skills and homework that's required. So, for example, prolonged exposure, you also have homework. The completion rates are highly variable, sometimes dropout rates of 50% or so. The success rates, highly variable, and in rare instances, exacerbation rates. Things get worse. Okay? Certainly don't want that. But the take home on this is all 3 of these have a substantial evidence base that in some patients there is significant relief. And if you carefully look at the literature, all 3 of those, the evidence is roughly equivalent. So you're saying, well, which one's better? It's about the same, okay, if you carefully look at it. Now, an important point, and this gets to about people not seeking treatment or not finishing treatment. Here's a paper in 2011 in JAMA by Dr. Charles Hogue. And this is a careful review of the literature that says, of that 20 years that I just did in drive-through fashion, that if you carefully look at it, some of those rates are overestimated. And I mean the rates of success. Because a lot of them have not used what's known as the intention to treat principle, which is if you offer it to 100, how many are successful? A lot of this reports on among those that completed. It doesn't take into account the dropouts. And that's a very important point. So what Dr. Hogue is saying here is basically if you take into account the dropouts, some of those success rates get cut in half. So that's very significant, and a lot of the literature, unfortunately, is framed in that circumstance. So you have to keep that in mind when you're trying to weigh how strong is the evidence and which is better. Okay. I'm really going to just, touch on this really quickly, just to make a point about where the field is now, where it's heading. These are not different therapies, but as you know, with the various therapies, we're looking at different delivery mechanisms. So group and couples, virtual reality, telemedicine, and the evidence is mixed, but what I would say is some of these at least tend to offer more likelihood for treatment completion. So something like telemedicine, if delivered properly, you would think would be more likely to result in treatment completion. So these are good things that we're looking at different ways to deliver therapy, no matter which one it is. Here's some ones that are not first-line therapies, but nonetheless have some evidence. And again, you'll get this PowerPoint presentation, and the references are cited here too if you want to look up the actual references. So medication-enhanced psychotherapy, acceptance and commitment therapy. This is used a fair amount in Australia right now. And this is one used by the VA called STARE, 8 modules. And so there's some evidence, not first-line. And here's even a couple more. So it just goes to show you that when I mentioned those core elements of trauma-focused therapy, people are ambitious, and they try to put together different pieces of that in different amounts of, I guess you'd say, emphasis. And so here's one, trauma recovery and empowerment model, and also dialectical behavior therapy, another type of CBT. And again, I don't want to go into details of all these. I want to make a summary point in a second. And now's the time. So up to this point, what I would classify all of these, so whether it's the prolonged exposure, cognitive processing, all of these, there's still a very strong cognitive component. And what I mean by that is, it's cognitive behavioral therapy, somehow trying to reframe the experience and, for lack of a better way of saying it, talk your way through it. That's kind of a harsh way of saying it, but reviewing the nature of the trauma, it's no longer a threat now, and trying to use cognitive processes to minimize the symptoms. That's the field historically, is a lot of that cognitive-based therapy of, talking it through, and you're no longer in danger. There are ways that you can minimize the symptoms. That's the field historically. Now let's look at this shift, okay? And before we get to ART, let's look at some of the others. Emotional freedom technique you may have heard, which is touching on both sides of your body and pressure points, similar to acupuncture, and it may sound a little bit way out on the edge in voodoo, but actually there's a little bit of evidence. There's a couple randomized trials, and one showed similar results to EMDR. So before you dismiss it completely, at least there is at least one trial with some evidence. And now we're looking at neurofeedback, so similar to biofeedback, and looking at what's happening during sessions in the brain and trying to train your brain. So I'm going to stop there before I go on to the next, just to make the point that notice that these two are not cognitive based. Okay? Now we're dealing with more physiological and memory, or the brain. And that's what Dr. Hernandez is going to touch on after me, is going to say, therapy is moving away from, quote, talking your way through it, to a physiological basis and a memory and a brain basis. Okay? And ART fits into that category. But these are supportive and may be very helpful, by the way. So no matter what type of primary psychotherapy is used, yoga is a good thing. Service animals may be beneficial. So these are all what I put into supportive. And now we're going to briefly just touch on accelerated resolution therapy, and of course your whole training session's on this, so I'm not going to go through each element detail-wise. I'd rather present the evidence to you, but just notice when I made that statement about physiology, okay, and memory, places disturbing images with helpful images. So you have a physiology-based and a memory-based. Okay? And that's what this basically says, and again, this is more of a broad presentation, and again, Lainey or her trainer, whoever that may be, will go through each of these steps, in particular about changing images in the brain with positive images, so that's the memory storage problem that Dr. Hernandez is going to talk about. Eye movements, that's where we're going to talk about the physiology, and that's what you're going to learn in your training. So again, this is an emerging therapy. It's very quick, it's very procedural, and again, it touches or captures the physiological basis and the memory basis. So these, if you're interested in a step-by-step, which Lainey or her trainer will cover, these are the basic steps, and you'll learn about an art scene, putting whatever is being worked on into a scene. These are the technical terms. Lainey might, or her trainer might use some different terms, but when you relive an experience in your mind, that's called imaginal exposure, and there's a whole literature on that. And then when you try to replace a negative with a positive image, that's called imaging rescripting. So there's a whole literature on this, and I have the references cited. So you're going to learn, that's the basic protocol, is put things into a scene, relive the experience. You're going to learn a lot about the physiology and the eye movements, though, of quieting down all the physiological response. And then the brain and the memory part. This is the brain and the memory part, changing it. So that's the imaging rescripting. So that's all going to be woven into this whole training session. So since Dr. Hernandez is going to give his presentation, here he is. I'm not going to play this video now. I'm not going to record this because you have the link, and if you're so inclined, this is a 4-minute video with one of our veterans that we treated, Brian Anderson, a former Green Beret. And I'll just say, you can watch the video, but he had some very extensive trauma, went through 4 courses of the conventional therapy, including prolonged exposure, 16 weeks, and was still symptomatic. And in this case, he wasn't part of our study. Lainey personally treated him in 1 session, and very successfully. So you can get if you want to watch that YouTube video, you can, instead of me playing it here now, you can hear Brian talk. And he's on the news for some other related issues. So what do we have to date? So this is emerging It's new in the sense, again, we're talking about physiology and brain and memory. We're the only group here right now at the University of South Florida studying this. I don't want it to be this way. That's the current state. We have completed 2 studies. I'm just going to show you data from one. And from those 2 studies, we have 5 peer-reviewed publications and a 6th that's in press. So not too bad. I mean, I'm a professor. We're supposed to publish. That's what we do. And we have an application in with SAMHSA to get ART formally evaluated as an evidence-based treatment for PTSD. It happens to be a slow process, so we're still waiting on the results. Okay. So I'm going to show you just the 2nd study. The first study we did do in civilians and got very strong results, but results from the 2nd study was a randomized controlled trial. And we compared ART, 29 service members and veterans, to what's called an attention control regimen. So they didn't get prolonged exposure or something like that. They got some personal interaction. And if they were randomly assigned there, we gave them a couple sessions to talk to a fitness trainer or a couple sessions to talk to a career counselor, because that's personal interaction. There might be some benefit, but it's not real therapy. And this will just tell you, the mean age was about 41, and we had mostly veterans, predominantly Army, a lot that had been deployed to Iraq, but the key thing are those arrows there, that more than 40% were on disability for PTSD, and basically 70% had tried other therapies. So the vast majority of our data to date, and what we're studying now, is what's called refractory PTSD. They've tried other things, whether it be psychotherapy and or pharmacotherapy. We don't get too many new cases, I guess you'd say. Usually it's after other things haven't worked as well as they could. So this is a way that we've presented our results, and each one of those vertical lines is a person that was enrolled in our study. And this, the measure is the PTSD checklist, which is a very commonly used measure. And a green line means more than a 10-point reduction in PTSD symptoms. And that's considered clinically and statistically meaningful. So not everybody, but the vast majority in the ART group are green line, and some of them very substantial. You got some blues that showed some benefit, but not the 10-point. And here's the attention control group with sort of a mixed bag. A couple got better, but a couple got worse. And if you compare the point, the 2 means, it was a 17-point drop in the ART group and only about a 2-point drop in the control group. And then if you took into account the dropouts, which remember I criticized some of the other literature and said we only had a few dropouts, but the conservative way is to say, assume no response. They dropped out no matter what, no response. It's 15 versus 2. It's still a big difference, and it's still highly statistically significant. The few dropouts we had, quite frankly, some of them got called up to active duty. There's nothing we can do about that. But nonetheless, we did it the conservative way, and in this case, you're going to learn 1 to 5 sessions, sometimes as little as 1. There was a mean of 3.6 sessions, so pretty quick. Okay. The other thing we've done, and this is the paper that's in press right now, as of this recording, is we've compared our response between civilians and military, because you might wonder, does it work better in the civilian? And so we have females, males, and everyone, and then we have civilian and military. And these bars dropping are basically where they start, where were they after treatment, and where were they about 3 months later. So that's the 3 time points. And all you have to do is look at the picture, and they pretty much look the same. Okay? So we're getting a good result both in military, civilian, male and female. And the real, quote, outlier of this is look where the female military start. They start the highest. And sadly, what we see in our clinic is the vast majority, overwhelming majority, have military sexual trauma. And that's a very, very serious problem that comes with a lot of psychopathology that goes with it. So they tend to get a good response, but that's what we're seeing in our work between males, females, civilian, and military. And there's explanations why that profile would be so high, but nonetheless, we're getting a good response. I'm going to wrap this up soon because I don't want to go too long. We had a very unusual finding in our military study that in addition to measuring PTSD and depression and alcohol use and the traditional things, we had a measure of pain. And a lot of our veterans came in with pain, a lot of it head pain, and about half of them had significant pain. Here is the drop in their pain. Okay, notice much more than the control group. You had one in the control group that had a nice drop, but highly significant. We published this. We're not exactly sure why that is, but we didn't treat pain. Okay, so in this study, we were treating PTSD, but their self-reported pain went way down. And my suspicion is because of the physiological basis that you're going to hear about throughout the training and Dr. Hernandez is going to talk about. So lastly, what I'm going to just wrap this up because this is meant to be brief. We are enrolling right now. We have our largest study to date. We're enrolling 200 service members and veterans. We're getting good results right now. We have lots of grant applications out there. We hope to do some broad Army-wide training. Our goal is just to get as much evidence as we can to document how this works, where it works, when it works best. So we're looking at both controlled trial evidence data. We want to do a study head-to-head against prolonged exposure, but also we want to do some mechanistic studies. We're looking a little bit at brain function right now. What changes? Some EEG parameters. We're doing that right now. So we'd like to document mechanistically what changes and how it works, and then how it stacks up to the current evidence-based therapies. So I'm going to stop there because this is meant to be brief and let Dr. Hernandez come up and give his presentation.
I'm the clinical director for our current studies. In the time that we have, I have a bunch of things I want to cover. Here's an outline of it. I want to go over the physiology of memory, memory and attention, all of these items here to basically give you a framework of thinking for memory, a framework for thinking of trauma, and a framework to think about how ART works. Because we're going to spend some time talking about how to make the transition from traditional therapy, as Kevin was talking about, that this type of therapy is more of an experiential-based therapy. And some of the